Clinical reasoning and decision making are two main areas which define paramedic practice. There's a paramedic's ability to make decisions and select treatments autonomously, which allow the profession to work in such a flexible and adaptable way. As the profession has developed, the scope of paramedic practice has increased exponentially. Gone are the days where the only drugs available were nitrous oxide and aspirin. Paramedics are now equipped with ECGs, ultrasound, and specialized drugs, all designed to improve patient outcome and reduce strain on the hospital system. However, none of these advances are useful if we're not judicious in their use. For this, paramedics develop excellent clinical reasoning skills to inform decision making at all levels of emergency care. While paramedic tools have expanded, they still rely on a solid foundation of systematic history taking and physical observation. Correct decision making relies on correct information. In medicine, this information is acquired via two pathways: physical examination of the patient and investigation of the patient's history. Effective information gathering independently relies on a paramedic's communication, investigative, and observational skills. Most patients have little medical knowledge or experience and do not themselves know which information is relevant to the situation and decisions to be made. Additionally, the patient will often have a poor gauge of the severity of their condition, which further compounds the difficulty of their examination. There have been many times where a patient has been focused on a superficial aspect of their situation, such as pain or another symptom, where in fact this symptom is part of a much larger constellation of disease that often paramedics cannot acutely treat or resolve on scene. Chest pain is a classic example of a presentation that requires thorough investigation and evaluation by a paramedic. The etiology of the pain can originate from an insult that is muscular, visceral, or bone in origin, and its source can range from immediate life-threatening severity to nigh irrelevancy. In paramedicine, we often treat for the most severe diagnosis that we can think of and work our way back as evidence presents itself. It is impossible, however, in the pre-hospital environment to absolutely exclude a diagnosis. However, we can make informed decisions based on the probability of a patient having a cardiac or non-cardiac pain, potentially respiratory or traumatic, based on their presentation and effective history taking. One of the main difficulties of a paramedic is understanding and acknowledging that there is a level of risk involved in all of our decisions, and that the information we're given can often be flawed. Medical histories may be second-hand, found on a letter at the scene of the incident. We do not have access to pathology, medical imaging. We do not even have a sterile examination room with which to treat our patients in. Our best tools are therefore investigative, and through the physical examination and history of a patient, we can remove some of the risk from our decisions and reach a good outcome for our patients. Decision making, however, is still inherently risk-based, and by choosing not to immediately respond based on our triage prioritization, we are still risking lives. However, were we to respond immediately to all calls for aid, then we only have finite resources and we would quickly be overwhelmed. We are choosing interventions on a small and large scale for our patients that will obtain the best outcome the most. On the large scale, paramedics must balance the application and commitment of our resources to find the best outcomes for the greatest number of people. Not only must each ambulance be considered when determining which job to commit it to, paramedics themselves must transport that patient to a hospital or healthcare facility, appropriately able to manage that patient's needs and care for them. The risk here is that the ambulance service and hospitals could reach a saturation point where all resources are tied up dealing with low priority tasks. If an unfortunately timed disaster or high acuity incident were to occur, the system would collapse and be unable to handle this. The whole system depends on appropriate decision making at all levels in order to function, from management right down to the paramedic in the field. Each layer of the emergency system must therefore trust that everyone is making appropriate decisions, and that these decisions, as much as possible, are influenced by clinical information that is relevant to the patient at hand. For example, If the previously mentioned patient with chest pain had been suffering from an MI, they would need specialized care, such as a cath lab, which is only available at a certain number of hospitals. It is therefore imperative that the patient reach the hospital and be seen by appropriate personnel within a time-critical window, or they may die or reach some other negative outcome. If paramedics have been crowding these hospitals with potential MIs, then not only will service deteriorate, but the staff themselves will begin to doubt the effectiveness of paramedic decision making and question our choices based on the sheer number of false positives that we bring them. It is imperative that we base our decisions on strong clinical reasoning to prevent this from occurring, not only to find potential high-risk patients, but to also correctly allocate resources to a lower priority patient that they do not clog the system and harm others. Clinical reasoning has been defined by Paramedic Principles in Practice, ANZ, in 4 parts. Firstly, the initial assessment of the patient determines the most pertinent signs, symptoms, and details of the patient. They advise a structured and systematic approach that can be applied to most situations, such as Dr. ABC. It is applicable to almost every scenario that you could encounter, and is an excellent starting point for assessing a patient. Secondary assessments, such as perfusion, respiratory, and urological assessment, as well as a pain and history survey, create a systematic approach to patients, and by practicing and repeating this approach, paramedics are less likely to miss pertinent information. Secondly, paramedics should then look to confirm their findings by considering differential diagnoses and then eliminating them as best possible. This is an exploration of alternative causes to the problem and systematically eliminating or prioritizing differentials over each other to obtain a provisional diagnosis upon which our treatment plan could be formed. Sometimes the presenting condition makes it difficult to identify any specific syndrome or condition to which the patient is suffering from. In these cases, we often treat systematically as best we can. However, the patients should be treated also for the worst possible diagnosis, and we should titrate this as appropriate to the patient's need. For example, patients in respiratory distress will often have one main concern: they can't breathe. But this could have been caused by a multitude of different things, similar to the MI earlier. It could be pleuritic, it could be cardiac, it could be skeletal-muscular. We just don't know in the field. Thirdly, we begin treatment. Clinical reasoning involves treating the patient with correctly indicated interventions and drugs. It is crucial at this point that the intervention is appropriate and made considering all available information. For example, in a patient with difficulty breathing, shortness of breath, and an audible chest abnormality, it is important to determine whether this patient is suffering from asthma, COD, or potentially even an APO incident. If you are wrong and administer Ventolin to a patient in cardiogenic APO, just based off the fact that they have difficulty breathing, you could raise the patient's heart rate beyond the safe limits to administer nitrates, and they would be contraindicated now for the patient and actively harm their management, even though that would have originally been the correct drug to give them. This example highlights that the decision to administer a drug needs to be based on accurate information, and that incorrect and poor choices can have severe negative outcomes that could otherwise have been prevented had clinical reasoning been used. Finally, the patient's condition needs to be regularly re-evaluated following the administration of treatment and continuing throughout the job in order to tailor intervention and management of the patient until they are discharged into appropriate cares. This includes not only looking for improvement post-drug administration, but observing for deterioration and side effects of the treatment. If necessary, the treatment should be adjusted to better fit the patient's needs and again re-evaluated. In this way, clinical reasoning should become cyclical and structured, similar to the systematic approach that we began with. In conclusion, paramedic decision-making has an effect on potentially the entire healthcare system, as individual unit choices ripple and affect response time, hospital wait times, all to other people. Paramedics are placed in a dichotomy where they must take ownership for their decisions and advocate for their patients, but also have to be aware that there are many other paramedics doing the same thing, and that there are limited resources for all patients together, and that poor judgment from them may result in excessive expenditure of resource and negative outcomes for another patient, potentially many more. It needs to be acknowledged that there is a risk in all of our clinical decisions and that we should try to mitigate this risk as best possible through clinical reasoning. Clinical reasoning begins with information gathering and investigation. It is important to remain curious when assessing patients in order to eliminate red herrings or differential diagnoses. These skills rely on a paramedic's ability to communicate with the patient and discern pertinent information to the case at hand. Decisions for the management and the treatment of the patient need to be based on information gleaned from these assessments in order to assure the best possible outcome. It is for these reasons that clinical reasoning and decision-making define paramedic practice.